The following is a presentation of the Healthcare Facilities Network. Hello and welcome to the Healthcare Facilities Network. I am your host, Peter Martin of Gosselin Martin Associates in the Healthcare Facilities Network. As always, thank you for clicking on this particular episode. I want to thank my guest, James Krause, for joining me today. James, welcome.
Greetings, Peter.
Greetings to you as well. So I will give a brief overview, and then I'll kick it over to James to give a little more detail. But James has more than 30 plus years of experience in healthcare planning, design, construction, master planning, benchmarking. This discussion will kind of revolve around James's unique approach to benchmarking, his work in benchmarking. We'll delve into detail. The reason James is on, he sent me an email after one of my Stephen Call episodes, and we started to talk about benchmarking. And he, over our discussions, I was like, well, let's have you on the show. And so that's how James is here. So he's been out on his own since 2016 in a consulting capacity. So that's a little bit over 8 years. Prior to that, he was with the Huron Consulting Group. As I said, more than 30 plus years of experience in healthcare planning, design, and construction. So James, welcome again. Thank you for the email, introducing yourself. What did I miss in that introduction?
Well, Peter, on this last journey of 100 plus hospitals, I've had many discussions and assessment discussions regarding benchmarking. And a couple of things that I found as I've talked to the C-suite, as I've talked to facility managers, is that a lot of the hospitals are kind of grouped together in terms of, say, 150 beds up to 500 beds. Mm-hmm. So one of the things that I've updated is developing a grouping of 3 tiers. So the tier 1 hospitals would be 450 beds plus, tier 2 would be 150 to 400, and then the smaller tier 3 hospitals, what I call tier 3. So that's the first thing that I've observed as I've talked to facility managers.
So can you tell me once again, James, because that's good detail. Can you tell me once again, you tier your hospitals by bed count. How do you tier them? What does that look like?
Well, the way I've organized the bed types is to compare the large hospitals, the tier 1 hospitals, to each other. Okay. And then the tier 2, of course, would have their own grouping in the tier 3s.
And we can see this down here at the lower right of the lower right.
And what I found is that the large hospitals are able to leverage their staff and their resources and accomplish a greater amount of square footage maintained per tech. And that is about 34,000 to 45,000 square feet per tech. Then when we get down to the tier 2s, they have less resources and less ability to leverage their resources. And down to 28 to 40,000 square foot per tech. And then that drops further in the tier 3 hospitals down to 18,000 to 28,000. So if we're going to look at the staffing benchmark, this gives a pretty credible breakdown of what is the realistic amount of square footage that can be maintained.
So that's
in these different groups.
So that's interesting. So you've tiered them, but you've all, I mean, typically, and you've obviously seen this. I mean, you look at some of the ASHI benchmarking that was done 10, 11, 12 years ago, you might see one employee, one facility's employee per 35,000 square feet of space, and that's kind of across the board. But what you're saying here and what's represented down at the lower right is bed count is determining how many square feet one employee can take care of. And that, I'm just going to tier 3. 18 to 28,000 square feet. That's significant, in my eyes, kind of significantly below that traditional benchmark where you're just saying 1 FTE per 35,000 square feet, per 40,000 square feet. Is that is what I've said accurate? Does that depict?
That's right, Peter. The smaller hospitals obviously have to spread their staff out to cover different areas, and there's a lot of overflow and cross training and so on. But this is a pretty realistic number in my experience as to how much square footage the tier 3 folks can handle. And if it gets above that, then we get into an issue of, are we getting our work orders completed? Do we have any non-compliant issues that are not being addressed? But this turns out to be a pretty credible breakdown of how much square footage a tech can handle. And again, I separate out the techs from the management and support staff. And as you could also see there to the right, that the management increases percentage-wise in terms of 10 to 15% of the tier 1s are management and support. And then that drops down to 18 to 22% for the tier 3 hospitals. So this is a good clarification of span of control when you get to these different levels of maintenance.
Wait, can you explain that to me again? So 10 to 15%. Can you explain that, the percentage of management staff? Does that say that the percentage of management? What is that saying? I'm sorry.
So what that includes the facility directors, facility managers, and the support staff to provide information for the management. So if we have a total staff of, let's say, 40 total department FTEs, and first of all, the techs we will look at in terms of the 34 to 45,000. That just applies to the working techs performing work orders.
Okay.
So then of that 40, 10% to 15% would be expected to be management and support staff.
Okay.
So that would be, out of 40, that would be 4 to 6 or so staff would be expected in a tier 1 scenario. And then we get into other issues in terms of, well, perhaps the management staff are also, in addition to plant ops, they may also be managing construction projects, or they may also be dealing with grounds or other issues. The intent of this process is to look at how much work is being performed to plant ops and maintenance. So if we have, for instance, the one FTE director, and half of their work is dealing with construction and other types of projects, then we would count that director as a 0.5.
Okay.
So the intent to go through is pure focus on maintenance.
Okay.
And so, that's the first clarification there.
What
We
did
just
you
want to deal with the maintenance staff, and even electricians and carpenters, painters will often get involved with construction projects. It's just what happens in our industry.
Right.
So let's say we have 4 carpenters. Half of their time is spent doing construction projects. So then I want to isolate out the 2 that are just involved with maintenance. So the numbers are pure plant ops, maintenance focused. Now it's okay that these other skill sets are doing other jobs and other types of skills, but that gives us a very clear understanding of what it costs for us, what's the time required to do work orders, which is basically the engine of plant ops, getting work orders done.
Yeah. What is it? Just what is the data that you've compiled through your benchmarking, James? Where did you accumulate it? What's kind of what's your source data?
The data comes from individual hospitals that I've assessed, working directly with the facility managers and the directors, as well as the C-suite, to accurately benchmark how well they're performing. And I went through a methodology from the very beginning point of over a period of a decade to collect the information, vet their information, and then process. And as I mentioned previous, look at each individual skill set and determine what percentage of that skill set is actively doing maintenance. And we want to exclude the activity they're doing outside of the plan ops maintenance activity.
Wow.
So through over 100 hospitals, I've been able to collect the data with this same methodology. And it's fascinating to me how compelling that information was in terms of once we've collected the data, processed it, how aligned they become. So over 100 hospitals is where my basic case study data has come from.
So what is this? We're staying just on this slide. I'm interested, your maintenance intensity factors. Can you explain that? What most campuses consist of different building types. What's the maintenance intensity factor? And can you give a little detail behind this top left?
Well, this is where I found that many facility managers end up very frustrated because, for instance, perhaps they're an older facility with a number of facility building condition problems. Well, they're being compared to a newer facility with less facility problems, and they feel frustrated because it takes more staff to be able to handle that age issue and that building condition issue. So what I found is that they don't feel they're being ranked totally accurately. So what I found as I developed this process is that there's a way that we can accommodate, first of all, the age and condition, but second of all, we have many different building types on a typical large campus that are being maintained by plan ops. So I developed a method here where I use the hospital square footage as the baseline. And if the folks are maintaining research buildings, clinics and medical office and so on, as my example shows here, for instance, we have 100,000 gross square feet of MOB, medical office, that they're maintaining. So it's important then to normalize that square footage and apply it to the baseline of the hospital square footage. And I found in the industry that it's about 1/3 of the maintenance level compared to that of a hospital.
Okay.
If you've got a 1 million square foot hospital, scenario A, being compared to 1 million square foot of hospital campus with scenario B, who maybe have 750,000 square foot hospital, but they've got another 250,000 square feet of MOB, clinic, outpatient services. They each have 1 million square feet, but case scenario A has more hospital square footage compared to scenario B, which is dealing with 25% of their buildings are lower maintenance intensities. So this allows us a way to normalize all the square footage, and then gives us the great opportunity now to compare any particular campus with any other campus, because we've normalized the square footage to what I call the adjusted square feet. And that adjusted square feet gives us great opportunity to compare a lot of other metrics. So as you can see on the list, based on grouping of percentages there, even the parking garage, they have to maintain the parking garage. Garages are often excluded from some of the benchmarking data.
Yep.
But parking garage is an 8 to 15% factor. So say 100,000 square foot garage would factor down to a 10,000 square foot adjusted, normalized square footage. And the facility managers really appreciate this because they know that they're maintaining these buildings, but they don't get any credit for it. So I found a lot of consensus that these are basically what the factors are for each of the building types. And then that allows us a lot of mileage to be able to look at a lot of other operational metrics within operations.
So how do you use this information, or what? So you normalize the square footage, and then what?
That allows us to then go into the adjusted square foot, look at their current working techs, and now we have an actual ranking as to how they perform compared to their peers on a square foot per working tech basis. And again, this would only be the techs, not the management or the support folks.
Yeah.
So we're looking at actual hands-on work being accomplished, primarily with work orders.
And it looks like and I'm just going by the slide here, you are also taking into account the age of the building, the square footage. When I say, you have total distance factor, travel distance, is that 20 miles versus 50 miles if you're a critical access hospital?
That's correct. And a lot of working techs for multi-campus sites is, say, an electrician will go from site A to site B to site C, and that travel distance time will factor in for them to be able to perform at multiple campuses.
Yeah.
And if that's an extensive distance, then we should account for that as well, to allow them to focus what's their time value on doing work orders from location to location. I've also found that roof square footage is another issue that often does not get into the mix. Extensive roofs require incrementally more staff to be able to go through and maintain any of the roof issues that are going on. So if we get above our zone between what's normal roof and what's extensive roof square footage, then I've got a factor that allows us to adjust for that, as well as the condition factor and the age factor. So there's a way to organize what that staffing impact would be. Again, comparing an older facility with a newer facility, that gets lost in the mix.
Yeah.
So this way we can identify, well, the age is about a 1.5 FTE extra burden for that particular campus. Or again, the condition issues. Those are extra burdens that do not get counted into the into a newer building with less problems. Now, through all of this, I'm careful to exclude the grounds, utility issues, union, non-union issues. And in some cases, a facility does not even have a central plant they buy energy. So that could be a 5 FTE swing, whether we have our own plant or whether we're buying energy. So I look at each one of those other variables on a point-by-point basis.
Wow. So in your approach to facility benchmarking, is maintenance intensity, like when you begin, is the maintenance intensity really is that the thing that's going to drive the benchmarking for the individual location? Because it certainly seems like it is, because all of these variables are present in every in every benchmarking, whether it's a system or 3 hospitals, 10 hospitals, 100. That maintenance intensity seems like it's that big driver, and you're accounting for that up front, correct?
That is the number one driver.
Yeah.
And so that's the first thing that, again, facility managers appreciate, because on the million square foot scenario basis, they now feel that they're being fairly ranked based upon their individual building types. And again, that starts out with normalizing all the square footage. That's step number one, to get that organized. Then after that is debated and discussed. Let's look at what the age impact is, condition and roof and so on. So that's a step B in terms of fine tuning their ranking based upon the normalized square footage.
And how long does that process take? How long does that process take to kind of get your arms around that maintenance intensity? It sounds time consuming.
If one has the data, it could be done in a matter of days or a week to get a high level sense of where we are. Do we look like we're in the zone of where our productivity should be, or are we overstaffed? And then we can identify by how much, or are we understaffed, which is becoming a greater and greater issue. But we start from that point as to, where is our baseline? So that has been well received from the folks in terms of, at least we're being compared and ranked accurately and fairly.
Okay, and then from your work, you have determined typical facility metrics, excuse me. Is that accurate? And is that what we're looking at here?
Yeah, so through this process, it's a 2-stage process where there are 3 fundamental items that are discussed out of the gates. So once we've collected the data, and it's important to vet the data and discuss with the facility folks in terms of, do we have the right skill sets in the right place? Like, are the carpenters doing 100% maintenance, or are they doing partial construction projects, or the electricians and so on? So we'll vet that and identify how many working techs we have performing maintenance. Then we apply the adjusted square foot number to that, the normalized square footage, and we come up with a very realistic ranking of how they are performing. And again, separate from the management and support staff getting in span of control, we want to look at that on a separate basis, since they are not the ones doing work orders. And then thirdly, with that adjusted square foot number, we can now apply the operating cost per square foot, broken out by what's the labor cost and what's the non-labor cost. So we get a good sense as to how they perform, number one, with working techs, and then also what's their cost, and how does the labor cost compare to the non-labor cost, which is supplies, purchase services, and so on. So that gives the big picture as to a starting point.
That's what I want to ask. relative to this process, the high level, stage one, the assessment, do most organizations, do you find that hospitals have that data for you? I guess in general, when you're trying to find it, where do you find that most hospitals, or do most hospitals lie in a certain area relative to do they have the data? What do you find out there when you're doing this?
Well, the data is actually pretty simple in that basically, number one, what is the total building square footage that is being maintained by the facilities group?
Mm-hmm.
And of course, we go through the normalization process. So all folks generally have that information. Secondly, of course, they'll have the breakdown of staff, director level support, and then by all the technical staff. And so they'll have that information. Then through discussion, we'll determine, well, are all of these electricians and all these carpenters doing 100% maintenance? Well, you know, this guy does 3/4 here, and the carpenters 50% doing other activities. So we'll clarify who accurately is performing plant ops maintenance activities. So again, we'll also have on the operating cost side, they'll have their operating expense sheet annualized in terms of last year, this year, and the projected year. So we could look at past, present, and future in terms of where their operating cost on a square foot basis stands. And something that does happen in terms of benchmarking, I've found that it typically goes towards how many staff you have, which is only half the story. The other half of the story is the non-labor cost, and we have to look at both. We can't just look at the staffing and the labor side. We have to look at both sides.
So are you, so you're saying that benchmarking doesn't always take into account that additional cost. They're just basing it on staff.
It often does not, in more cases than not. And let's just take a case where a facility manager has to do a, mandated staff reduction.
Mm-hmm.
Well, they're already probably at the breaking point in terms of they probably already gone through some reductions, and now we're asked to go through another one. And what I'm saying is that what they'll do is, well, we have to do what we have to do, so let's cut 4 people. Well, you and I know what's going to happen is they have to get the work done.
Right.
So they'll outsource it, and that's not a cost savings, but it's a cost shift from an employed FTE to an outsourced resource. And so the cost probably remains the same or increases now that we have to outsource it. So and directors often get frustrated with that fact that folks don't seem to understand I have to get the work done, and you can cut 4 people, but I'm going to make it up on the non-labor side.
Yeah. Yep.
And I guess that, to me, seems to be pretty obvious, but when the edict comes down in terms of reduced staff, they don't take the other side into account.
Gotcha.
And that's important.
This concludes episode 1. Please return to the Healthcare Facilities Network in the near future to view episode 2. And as always, thank you for watching.